Duly Noted, 3/4/2018. Hi, I'm Dr. Kathy Dooley. I'm here at the amazing Livestrong Primal Fitness in Melbourne, Australia, with these two incredible blokes. Yeah, that's what we call blokes. Yeah. So Richard, would you like to go first? Where are you from?
Hi, I'm Richard from Sydney, Australia, with Balance Health and Performance.
And he's allowed us to show a little bit of dysfunction that you have going on in the wide plane. Yeah? Just a little bit, not a lot bit, just a little bit. And then the amazing James.
Hi guys, James, Sydney, Australia as well, and I too work with Rich over here.
So these guys both have wide plane or frontal plane dysfunctions in the pelvis relative to the femur. And what's important to assess is that they're quite different. What we're gonna do is we're gonna do a very sassy test. You guys ready to do a sassy test?
Yep.
We're gonna do a sassy test called the hip transition test. So basically you pick a foul line. Our foul line is gonna be right across here. And we have to make sure we don't cross the foul line. That would mean that we're not moving in the frontal plane, but we're instead encouraging transverse plane movement to look and assess the abductors and adductors relative to each other, along with our lateral flexion of the spine. We want to see quiet happen to the spine, and we want to see a lot of trochanteric movement side to side. Okay? So let me just show first what a relatively normal test would look like. We're going to shift to one side and shift to the other side. No foul line crossing, that would mean we're trying to encourage internal rotation. No walking away from the foul line, that would mean that you're trying to use external rotation. We also don't want to see spinal movement, like lateral flexion of the spine. We want that to be quiet and for there to be trochanteric movement. So Richard, would you like to go first? Let's put you in the hot seat. And Richard's going to move to the left. And he has fairly good adduction and abduction. People get very confused when they see this movement because they see the body shifting this way and they think that's abduction. But actually, the femoral head is approaching the navel, making this adduction. So as he moves to the left, this is the adducting side, and this is the abducting side. And you can see he has no real trouble with that. He doesn't cross the foul line nor move away from the foul line. He has a really nice plane movement. Can we see that one more time? Good. No excessive shifting through the spine. Now, Richard, move to the right. And oh, if there were a babe, he would cross that foul line. So, unfortunately, he's trying to internally rotate his femur rather than adduct it. And people do that when they can't let go of the abductors on the same leg, because the abductors largely are internal rotators as well. So let's watch that one more time. Can you move towards me, Richard? So he can abduct this right femur very well, but he can't let go of his abductors as he moves to the right. And he crosses the foul line. So we would look for you to have down-regulated adductors and up-regulated abductors. And when we did our NKT testing this weekend, we actually found, was it glutamide inhibiting your adductor?
Yep.
Yeah. So we did a glutamide release, and then we did an activation of adductor magnus for you, no longest for you. So we'll do that in a mere moment. Now James is another version of this issue. So James, you move very well to the right, yes?
Really well.
Okay, so you're the opposite of Richard. Okay, in lots of ways, I'm sure.
Definitely.
Yes? Okay, so let's move you to the right. So abduction, adduction looks fairly good on both limbs. This is adducting, that's abducting. And now move to the opposite side. And we have a lot of things happening there. And a lot of them are happening at the spine. There's a lot of lateral flexion bias, indicating that he has trouble adducting on the left femur, abducting on this femur. Even gives us a knee bend to show us he's not really comfortable with being able to go into that position. He also kind of moves away from the foul line. The difference here is that it's both limbs that are the problem on James. For him, the left adductor compartment and the right abductor compartment are limited by this excessive spinal movement that we see here. And James, you had shared with me that your loss of internal rotation and adduction on the left hip was also preceded by a lumbar spine issue?
Yep, lumbar spine or suspected disc issue.
Yeah. So disc issues often show up as a hiking on that same side due to down-regulation of multifidus, up-regulation of quadratus lumborum. And when that happens, it throws off your pelvic plane stability on both limbs. So you would see a discrepancy usually on both sides. So the fix for you guys is a little bit different, right? For you, we had to release your gluteus medius, decrease some of that tension, and then teach you how to adduct, right? For you, we have to teach you how to adduct and abduct, but we have to downregulate your QL first. But the finisher is basically the same thing. After we downregulate your QL, after we downregulate your gluteus medius with a little bit of release work, then we put you guys into a side lunge test. So let's get you guys both in side lunge. So you guys are going to be moving towards each other, it looks like. Yes? Yeah. So for you, we're going to be doing longest. So your feet are going to be basically in the same plane as each other. And then for you, we're going to be doing Magnus. We're going to step forward. If you guys need a cheat sheet for this, the adductors are please, baby, love my groin for the lunge position. Pectineus, brevis, longus, magnus, gracilis. And the feet are always facing forward as much as you can. So both your feet are going to face forward, but Richard's going to be feet lined up, whereas James is going to bias a little bit more towards magnus on his left side by going a little bit more anterior. Now when you guys have to go into adduction, because you're both missing adduction on these limbs, we have to make sure that happens through your trochanter. So do you guys mind putting a hand on your trochanter? And we want to make sure that you're not leading with the knees. So when you push, it's through your hand. And that will be adduction. We know we don't have side-to-side plane movement of the knee, so this has to happen where your hand is. Okay, I'll keep you honest, all right? So here we go. You'll take a nice deep breath in, and then you'll push yourself into adduction. You can let the knee soften, but let the movement happen actually through your femur. Beautiful. Excellent. So a lot of people will try to compensate. These guys are not doing it, but they'll try to use the femur down at the knee rather than the femur at the hip. And they share the femur, these two joints. So if the knee is allowed to move first and most, the hip will lock up. But you guys did such a great job in not leading with your knee. Okay? So do it one more time so they can see at home. And they're working to push the hip into adduction. For James, he's making sure he doesn't recruit QL. For Richard, he's making sure he doesn't try to internally rotate with his abductors. Excellent job, gentlemen. Very nice. And when they go back to their transition test, they should do it a little bit more freely. In NKT, we always find a compensator, release it first, and then activate what's inhibited. So these guys have different reasons why their transition test fails. But ultimately, they have the same weird corrective strategy, only a little bit of tweak for Magnus and Longus, respectively. So we hope you found the transition test helpful. Remember to use a foul line. Don't let them cross it. Don't let them go away from it. Don't trade off transverse plane movement for frontal plane movement. And if you're someone like James who has a history of radiculopathy or low back pain, look for them to do a little high action, or look for them to do a little bit of lateral flexion biasing. That means that their main compensator is going to be in their back. Thank you so much, gentlemen from Sydney.
Thanks,
really
Kathy.
appreciate
Cheers.
you showing the dysfunction, even though you're big, strong, amazing people, great therapists. I know, but it still matters to get rid of your dysfunctions before they become painful, right? Okay, duly noted. See you later.